And as we know, retina is the only place in the whole human body where you can see the blood vessels and see the nerve, unlike any other place in the body. And so we have a lot of internal medical problems affecting the retina, the retinal blood vessels, the retinal nerve, in fact. So all this would be there. And so who else other than this wonderful panel to ask our doubts as to how seeing something from the eye, what are their thought processes in what is happening to the human body in total. So we cannot in silo differentiate between retinal changes and manage them independently, whereas we are working as a team involving them in the management of our patients holistically. And that is what we will basically look at. And let us look at first endocrinology, because that's the starting point of diabetic retinopathy is diabetes. So let us think that there is a new diabetic who comes to you, Dr. Nisha. So how would you think about it from the ophthalmologist perspective also? Any new diabetic who comes to you, diagnosed now.
Thank you. At the outset, let me thank Dr. Gopal, Dr. Mini, and the whole organizing team for having invited us. Actually, being in Amrita, I don't have to think about it because Dr. Gopal has set up a wonderful endo-ophthalmic clinic. So any patient coming to endocrinology will be seen in ophthalmology. That should be the what endocrinologist likes is that. So everyone should be screened by ophthalmologist. But if we are not fortunate enough to have such a setup, the recommendation is type 1 diabetic patients 5 years after onset or at the time of puberty. Whichever is earlier, you need to screen the eye, and then depending on the findings in the eye, you plan the follow-up. Type 2 diabetes at the onset, because around 30% can have retinopathy at the onset of diabetes, because most of it is undiagnosed usually. We have a new cluster classification of diabetes where we divide diabetes into insulin-resistant diabetes, severe insulin-resistant diabetes, insulin-deficient diabetes, mild obesity-related diabetes, age-related diabetes. So there's a cluster classification like that. So when we see the patient, we will know who is prone to develop this diabetic retinopathy. So this insulin deficient is not the type 1. In the adult, there's an insulin-deficient type of diabetes where they require insulin early on. They are more prone to develop diabetic retinopathy than the insulin-resistant types and the age-related diabetes and all. So such profile of patients, we make sure that they go to the endo-ophthalmic clinic. Then pregnancy. Before planning any diabetic, before planning pregnancy, we need to have a retinopathy checkup, and during the first trimester, and then depending on the findings, we'll plan the follow. So this is the broad.
Thank you, Nisha, for bringing out that particular cluster classification. So I would just like to delve a little deeper, because we as ophthalmologists would want to know which are the patients who progresses faster and which are the patients who would probably stay stable. So you mean to say that when you have an insulin deficiency in an adult patient with type 2 diabetes, they progress much faster in diabetic retinopathy than the others. So as an ophthalmologist who are seeing diabetic retinopathy, again, the other thing is, now what should be my thought process in terms of insulin deficiency? Like all the diabetic patients that come to us, we do not differentiate them based on this cluster classification, insulin deficient, insulin resistance, etc. But if we start doing that, then we would be able to pick up patients who are progressing faster. So how do you do that?
We don't document which type of diabetes. Sometimes we document, it's very easy to document the insulin-resistant type of patient who are very obese with a pot belly and severe acanthosis, but they are at more higher risk of renal disease rather than retinopathy. The other ones are certain lean people. Actually, the cluster classification needs a genetic, C-peptide, so many things you need to actually classify. But clinically,
but if I want to actually do
that means you have to do the TCF gene, the C-peptide levels, the age of onset, the BMI, all those. Clinically, when you see a patient in the clinic, it is these lean diabetic patients who require insulin early on in the course of the disease. So you can ask them how many years of diabetes. See, duration of diabetes is the most important risk factor. Type 1, today is the onset, and so you look at diabetes 5 years later. Type 2 is not like that. But again, if you see a lean diabetic patient who is not type 1, but then he is requiring insulin fairly soon after diagnosis, maybe usually the 10 to 20 years later only they will require insulin, but it again depends on so many factors. But someone who is requiring insulin OAD failure in the first 5 to 10 years and all, we think they are insulin deficient diabetes. And plus, they will be leaner, not the obese that severe insulin resistant type. So those are the patients who will progress for retinopathy. Plus, again, duration is more important. So longer the duration, you have to be more careful. And associated factors, hypertension, obesity, dyslipidemia, these are the like anemia. Anemia is very important risk factor for progression of diabetes.
Okay, thank you very much for bringing that. Now, a new diabetic retinopathy an ophthalmologist is diagnosing. So it may be at different levels. Some may be mild diabetic retinopathy, or some may be diagnosed at more severe diabetic retinopathy, or even proliferative diabetic retinopathy. So what would be your lifestyle modifications, exercise, and also I would like to ask you next on, okay, that let's talk about this, and next we will talk about treatment. Yeah, lifestyle modifications for a newly diagnosed diabetic retinopathy that an ophthalmologist should definitely tell the patient.
Okay, I think Dr. Sarida is running the lifestyle clinic, so she will be more dealing with it in detail. But then for me, I would like to emphasize that they should, what the usual recommendation is moderate exercise, 150 minutes of activity per week, and 2 days of resistance training. But if you have a severe or a moderate to severe or a PDR, you should avoid doing strenuous exercise, especially weightlifting, heavy weightlifting, head down postures, yoga. We are all passionate about yoga, so head down postures, something which involves Valsalva maneuver, which will increase the.
So heavy weight training also should be avoided in these people?
In the severe and the PDR, severe NPDR and the PDR, where the risk of capillary leak is more.
All right, so that would be the lifestyle modifications, which we'll come to also a little later. Now, will the stage of diabetic retinopathy influence your glycemic control? Like, for example, in early diabetes, should you be aggressively controlling the diabetes, as compared to in a late diabetic retinopathy, you would not be very aggressive in it? Would there be any considerations like that based on the stage of diabetic retinopathy?
Yes, absolutely. Because early, the point you diagnose a mild NPDR, few microaneurysm, you tell them that you have started developing complications. So people are more concerned about the kidney. So you say that eye is involved. Now next the kidney will be involved. They will all be very they will take it seriously. So early diabetic retinopathy, you need to have an aggressive control to prevent the progression, as demonstrated by a lot of studies, UKPDS, DCCT, everything has revealed that. But in a later stage of diabetes, usually in a type 2, in a type 1, it is unheard of, it's very, very rare to have a nephropathy without a retinopathy, but in type 2 it is not like that, because a hypertensive retinopathy, everything can contribute to the retinopathy. So in that case, so in a late stage of diabetes, when there is nephropathy, CKD and all, the aim of, and they will have some associated cardiovascular disease and all. So many studies have shown that very aggressive control when they will predispose them to hypoglycemia, especially when there is a CKD and a CAD, and that has shown to be of poor prognosis than a very strict control. So depending on the associated, not retinopathy per se, but the associated nephropathy, CKD and the CAD will make us like little lax in strict control. And again, the rapidity of control is important. You are not suppose it is a very severe PDR, very severe NPDR, or a PDR which has not leaked. If the recommendation is you have to reduce it slowly. That is, HbA1c should be reduced by around 1.5% in 3 months, not more than 2% in 6 months. But having said that, you don't know what, like you can't predict. When we give treatment, we give less aggressively. But the thing to do is you call them monthly and ask for a monthly retinal evaluation, and then you titrate the dose. So you have a control over what you are doing.
In some of the studies, it has been shown that when you rapidly or aggressively control the diabetes, then diabetic retinopathy worsens a little bit initially over the first 6 months or so, which stabilizes over the first year. But anyway, in the later phase, nephropathy also sets in many cases, and probably those patients are amenable to hypoglycemia also. So sudden hypoglycemia, and they may go into spells of complete hypoglycemic attacks. Yeah. So again, less aggressive at that point of time. Will starting of insulin be a consideration in a patient who do not have diabetic retinopathy? Oral anti-diabetic drugs definitely, does it have equal hypoglycemic power as much as insulin does? Like for example, in an early or no diabetic retinopathy patient is coming to me, which means it's fairly early in the disease. We know that from DCCT, UKPDs, everything, we know that if you control the diabetes aggressively down, we have great benefit. So with oral anti-diabetic drugs, will we be able to achieve the same glycemic control as much as the insulin?
See, we have more and more drugs in our armamentarium now, the GLP-1 receptor agonists, the SGLT2 inhibitors and all, rather than the old sulfonylureas, metformin and all. So with a combination of this, we can actually attain a good glycemic control as equivalent as that of insulin with greater cardiovascular and renal benefits. So if the only problem is the affordability in our patients. So if affordable, they can have a single drug, there is nothing like insulin. The average HbA1c reduction is around 1% for most of these drugs, whereas with insulin it can be anything. Insulin can reduce by anything. But if a combination of drugs, we can have a good glycemic control. But the only problem is with the GLP-1 receptor analogs, which are the hype in the market. The company has no time to produce insulin. They have stopped the production of insulin cartridges to bring out this GLP-1 receptor agonist nowadays. So, because that is a weight loss, that is being marketed as an anti-obesity drug as well as an anti-diabetic drug. It is because of the studies have shown that the introduction of GLP-1 receptor agonist has worsened diabetic retinopathy. Okay. That is mostly because of this rapidity of the control. And again, the risk of non-arthritic.
This is the glitazone group you are talking about?
No, GLP-1 receptor agonist. It is called the semaglutide, incretin group of drugs, which is a semaglutide, which is oral only is available in India, injectable is available only outside. So it is with the injectable semaglutide that this worsening of diabetic retinopathy and the risk of anterior ischemic optic neuropathy is found to be little on the higher side. Okay. But again, it is not a conclusive, worsening of retinopathy, there is conclusive evidence, but as you said, it's stabilized over time. Okay. But anterior ischemic optic neuropathy, the retrospective studies have shown that the risk is around 4 to 7 times higher when it is given for diabetes and obesity. But we don't have the injectable semaglutide as of now. We have its analog, which is called tirzepatide, which is launched in India, which is a dual GLP-1 receptor and a GIP receptor agonist. So there is no reports of any adverse effects like that with tirzepatide as of now, but then it may be a class effect mainly related to the rapidity of the control. And I read some ophthalmology journals, it says that some crowded cup or something, I couldn't understand. So if OCT demonstrates some crowded cup where there is a venous, lot of vessels around, the risk is more. So I think
risk of AION. So AION is a condition which is not very reversible. So if 4 to 7 times the risk is there, then that is a little higher, very high risk.
That was reported from a neuro-ophthalmology clinic, where all these rare cases get referred. So there is a referral bias there.
Okay. And the next thing would be, any other drug which you have, like the glitazones, like we are treating a diabetic macular edema, it is not showing the improvement. Then if the patient is on glitazone, we may need to change. Yeah. So what is your thought on that?
Glitazones, because the problem with glitazone is that government approves it one day and then it bans it the next, after a few hours, then they again remove the ban. So we will be answerable to our patient. They will ask me why you gave a banned drug, and then we are telling now government has lifted the ban. It's actually a really good drug if you choose the patient correctly. It's like the lean diabetes and all, it's actually a very good drug. But because of this, our usage has reduced, and it has some association with bladder cancer, anecdotal reports and all.
Okay.
So we usually don't use, but if there is a macular edema, we will stop. It is again bad for the bone also. Pioglitazone has osteopenic effects also. So
And compared, one more, the last question that I want to ask is about the lipid management. Like for example, a cardiac patient, generally they want to keep the lipids so low. Do you want to keep the lipids, especially the ones with a lot of hard exudates, which are basically cholesterol? Do you want to keep the lipids very, very low with management?
the evidence for lipid lowering and retinopathy is actually with fibrates. Fenofibrate has shown to reduce the risk of retinopathy, plus fenofibrate plus statin use, but the level of cardiology, which cardiologist means 55 and 70 and all, I don't think there is any data to show that has a like adverse effect on retinopathy. I am not sure. Protective effect is not there.
Then there is no point in doing that.
Yeah.
Unlike in cardiology, right?
For retinopathy alone, I don't think that is needed. That recommendation is only for atherosclerotic.
Any questions to Dr.
disease.
Nisha? Then we would move to the nephrology perspective. Thank you, Dr. Nisha. Any other questions from the audience? Yeah. No, can you come to a mic? Can you give a mic? Can you come here?
Can we as ophthalmologists start fibrates? Is there anything that we need to
Side
look
effects
for?
or anything like that that we need to do?
Fibrates, the side effect is muscle damage and some amount of liver toxicity, especially when it is combined with statins.
If the lipid profile is absolutely normal,
There is no recommendation like that. When you are giving for triglyceride, it is shown to improve the retinopathy. And now for triglyceride, we have another drug, icosapent and ethyl ester, which is actually which has got cardioprotective effect. The fenofibrate has not shown any cardioprotective effect. So we tend to use, if patient
for the sake
for
of
retinopathy alone, actually there is no recommendation. I don't know, without monitoring just like that.
Again, Sheena, I
don't
also feel that we should not look at it in silos, because as ophthalmologists, we are looking only from our perspective. It is better for a physician to look at all around things to start a drug like that.
That's exactly why I'm asking the question.
Yeah, thank you. Thank you, Dr. Nisha. Now let us move to nephrology. Now we have looked at diabetes and its control. Now let us move to nephrology. When should the first question would be that when should an ophthalmologist would be referring a case, because we would be seeing diabetic retinopathy, and when should we refer to you? What would be the basic things that you think we should do before we decide that, okay, nephrologist should see? What is your thought on that?
Good afternoon, one and all. Let me thank Dr. Gopal, Dr. Mini, and the whole organizing team of KAAZCHA for giving me an opportunity to be part of this panel. So coming to Dr. Gopal's first question, obviously when you see that patient has retinopathy, most likely the patient is having nephropathy also. So if you feel that there is any telltale evidence of retinopathy, straight away the patient needs a nephrology consultation for sure. And the basic investigations is basically 3 tests. It is very simple to rule out a renal involvement. Look for urine routine, whether there is albuminuria. Look for microalbuminuria. Look at a creatinine and do an ultrasound abdomen. So these 3 tests will conclusively tell you whether there is a very early evidence of renal involvement or not. So 2 of the questions you are likely to ask me is already answered by Dr. Nisha. One is, when do you evaluate a patient from the nephrology perspective if the patient has diabetes? She has already answered that. At the diagnosis of type 2 diabetes, because we don't know when the diabetes has started. Type 1 diabetes, of course, 5 years after the onset, we need to check them. And the second question, what you asked, is applicable for nephrology also. How tight should be the diabetes control? Of course, when the CKD progresses, we'll be a bit relaxed so far as blood sugar control is concerned, because patient can go in for hypoglycemia.
Yeah, so that's very important. So nephropathic patients would definitely go for hypoglycemia if the control is more. But again, probably a patient who comes to us for diabetic retinopathy screening, it will be really good to have a urine routine, microalbuminuria and creatinine. And if they are completely normal, then they are not into the nephropathic range, and probably we should check it once in every 6 months or yearly.
If the patient is having a duration of diabetes of 5 years duration, the recommendation is that annually you need to check once in a year if everything is normal.
Okay. And if about 10 or 15 years duration?
Again, if there is nothing to start with, it is again annual only.
Annual only. Okay. And if there is a problem, we refer.
Yes.
All right. Okay. So we know that proliferative diabetic retinopathy is equal to nephropathy, definitely. In any amount of retinopathy, there will be a lot of patients whom we are seeing who do not have microalbuminuria also. But the moment the patient develops proliferative diabetic retinopathy, it is equal to nephropathy. Definitely they will have. And nephropathy also, 100% of your patients will have some element of retinopathy, almost 100%.
Yes.
So a patient who you keep on, the patients whom we are not seeing, the patient who is a diabetic, who is initially detected to have a nephropathy because of any reason, maybe diabetic, maybe non-diabetic, what would be your approach if you say that there is retinopathy versus no retinopathy? A patient who is nephropathic, who is diabetic for some time, I would say there is no nephropathy, no retinopathy. Or I would say, okay, there is severe retinopathy. Is there a difference in your mind?
It's a very good question. Yeah, once we see that a patient has diabetic nephropathy with evidence of albuminuria, because there is a subset of patients who, those patients will not be having albuminuria. So, to put things into perspective, now we don't say it is diabetic nephropathy, it's a DKD. DKD is a broad spectrum of kidney diseases related to diabetes. Diabetic nephropathy is part of DKD because DKD involves diabetic nephropathy, diabetic tuberous disease, renovascular disease, other non-diabetic, other renal diseases related to diabetes also. So when you say that patient has retinopathy, along with diabetic kidney disease, it is mostly a diabetic nephropathy itself. That means there is a significant glomerular component involvement. Patient is likely to have proteinuria. The proteinuria is likely to progress, and the patient is likely to have a faster progression to end-stage renal disease. So diabetic retinopathy is a big risk factor for a patient with glomerulopathy and proteinuria for the risk of progression. So our prognostication totally changes. The patient has a retinopathy, he is likely to move faster in the CKD track towards end stage, whereas there is no proteinuria, whereas there is proteinuria but there is no retinopathy. Obviously proteinuria also will not be that much. So progression is likely to be a bit slower. To cut the long story short, a patient with having creatinine of 1.5 with proteinuria and retinopathy is a high risk, whereas creatinine of 1.5, no proteinuria, no retinopathy is low risk. That's it.
Okay. So that brings the change. So there is retinopathy. The presence or absence of retinopathy makes it really important into the nephrologist perspective. So that is very important. Another thing which is very commonly used is we all do fluorescent angiography. And whenever we take an informed consent for fluorescent angiography, people will say, will there be nephropathic problems? Then what we do is we will refer to a nephrologist to get an opinion regarding whether the patient can undergo fluorescent angiography. Can you give us fitness? So what is your thought on that?
Again, this is a very interesting question, and I need to answer this very categorically. FFA is not going to produce a renal dysfunction worsening because of so many reasons. One, because it is sodium fluorescent. The volume of contrast which we use is hardly 2 ml. Am I right? To 2.5 ml. 10% of sodium fluorescent, 2.5 ml. This volume is actually too insignificant to produce a contrast-induced nephropathy. So I think the meta-analysis and a lot of studies have looked at this, and the evidence is very clear that FFA is not going to lead on to renal dysfunction worsening. That takes us to another point, that what is contrast medium induced nephropathy. That's also important. So contrast medium induced nephropathy is actually seen in patients with, once we give iodinated contrast. Iodinated contrast is the one which is toxic to the kidneys, and usually, by and large, the thumb rule is that the volume increases more than 30 to 50 ml as the cardiologists use. There is something called Meharan scoring and all, which will tell you there is a risk of nephropathy induced by contrast. Then the risk is more. So it is we can categorically tell that there is no need to be worried about FFA, especially if the volume is only 2 ml of fluorescent dye. irrespective of the stage of nephropathy,
Okay.
whether it is grade 2, 2.5 or 5, or maybe close to dialysis.
So it's very clear, fluorescent, there is no contraindication from the nephro point of view. All right. Okay, now another important thing is in the presence of, we all know that from UK PDS and from a lot of other studies that hypertension is a very important factor for progression of diabetic retinopathy as well. So in nephropathic patients, sometimes we feel that the blood pressures are not getting controlled, and that may also account for progression of diabetic retinopathy. So is management of diabetes of hypertension in nephropathy more difficult? What do you do for that? One is about prevention before retinopathy, nephropathy sets in the presence of hypertension and diabetes, and second is after they set in.
It appears very paradoxical that my statement I am going to make. Once the patient has established nephropathy with a significant proteinuria and progressive renal disease, control of diabetes has, the role of control of diabetes, stricter control, has nothing great to play. It is control of hypertension. It's very important. So once the patient's GFR is actually, usually GFR less than 60 means CKD stage 3, then it is going to progress. So usually if the GFR is less than 60, to be very precise, less than 30, then we as nephrologists will not be too much concerned about a very tight blood sugar control. But hypertension control is extremely important because that is probably of the risk factors, hypertension control is probably the most important factor, which will tell you that this kidney disease is going to progress. So hypertension control is second thing, it is very important, probably more important than control of diabetes. And second thing, control is difficult. You need probably 1, 2 or maybe 3 drugs for control hypertension. Probably I am not going into that because based on the GFR we'll be starting the patient on ACE or ARB, and based on that we'll be stepping up the blood pressure. There is significant proteinuria, the blood pressure control should be less than 130/80. If it is not there, it should be less than 140. General, I'm telling you general. But to reach this target it is not very easy.
Okay. So before we go into one segment which requires a little bit extensive discussion, that is anti-VEGF and nephropathy, I would just ask you, as ophthalmologists, we also give antibiotics. We may give Diamox in certain circumstances. We may give NSAIDs after surgery for pain, etc. So which are the drugs and what are the drug modifications? Maybe we will have some viral retinitis in which antivirals may be given. So what are the drugs, common drugs, which ophthalmologists should know, which has a kidney problem, and we should generally try to ask you what dosage we should give?
For that, actually, I would like to try to answer in this way. So far as a nephrologist is concerned, any drug, there are only 2 questions. One, is this drug inherently nephrotoxic? Question 2, what is the drug dose modification required for this drug? These are the 2 questions to be answered. To be very frank with you, there are only very few drugs which are inherently nephrotoxic, like aminoglycosides, amphotericin, NSAIDs, cisplatin, acyclovir sometimes. Because there are certain drugs which can directly involve the glomerulus that can precipitate an acute kidney injury, precipitate acute tubuloindustrial nephritis. To be very honest, any drug can produce an AKI, that's different. But commonly, these are the drugs which need to be avoided. So, irrespective of the degree of renal dysfunction, if somebody is asking me, can you start the patient on amikacin? I will say that no, you don't start. You try some other drug. No, only amikacin is sensitive. Okay, then we will advise dose modification. So that is answer to question number 1. Question number 2, any drug which is renally excreted needs a renal drug dose modification. Whether it is amoxicillin, whether it is ampicillin, whether it is cephalosporin, whether it is vancomycin, will need dose reduction.
So that will be beyond what creatinine level or something like that?
Thumb rule, GFR less than 30 ml.
We don't generally calculate GFR. So
simple. I'll tell you.
GFR
less than 30 ml, 30% reduction in the total drug dose. This is the thumb rule.
Okay.
How do you calculate the GFR? Basically, there is a simple formula called the eGFR calculation is based on Cockcroft and Gault. This is a formula. 140 minus age into 18 kilograms will be 72 in the creatinine. This is a very simple formula. It is available in apps also. You just put the age, weight, and the creatinine, you will get the value into 0.8 for females. So this formula has certain fallacies for the practical purposes. That's another called CKD EPI formula also. These are the 2 formulas we use. But Cockcroft and Gault is more simple. So based on that, you will come to know what is the GFR. And based on the eGFR, we can.
So 30, less than 30 is 30% reduction.
Thumb rule.
Okay.
Less than 30 ml is 30%. If the patient is having, the drug is renally eliminated. If the drug is not renally eliminated, there is no dose reduction required.
Okay. So any antibiotics, any drug that we give, we have to look into that. Even though they are not
Renal clearance.
Yeah, renal clearance. Yeah.
Should know the renal clearance. Otherwise, if there is no renal clearance, there is no need to dose reduce.
So now let us move on to the most important stuff here, anti-VEGF and nephropathy. So we have in our armamentarium, we have right from bevacizumab, ranibizumab, aflibercept, brolucizumab, faricimab, and finally we have the dexamethasone long-acting implant as well. So some of the conditions were there is frank nephropathy and there is some progression, and the patient also appears to have some anxiety and progression of nephropathy and all. We will, in diabetic macular edema in RVO and all, we may move to a dexamethasone implant without a problem. But there are some patients in whom anti-VEGF is currently the first approach always in all ophthalmologists' minds. And so we also did a small study on what happens in diabetic patients who are on anti-VEGF. So the initial study was like 1 month after the anti-VEGF, what was the change in GFR as well as in patients who have creatinine less than 1.2 or at different GFR levels, more than 60, 60 to 30 and less than 30. And microalbuminuria also less than 30, 30 to 300 and more than 300. We looked at 40 patients, and after 1 month, there were 3 patients who progressed after 1 month in terms of reduction of GFR or increase in microalbuminuria, and 1 patient changed from fourth stage to fifth stage, not fourth stage to fifth stage, 4A to 4B. So there was some small change in the nephropathic grades, but we require more long-term results. And I think Dr. Rajesh has done an interim analysis of 6 months of patients. One group of patients who received anti-VEGF, the other group of patients who did not receive anti-VEGF. Rajesh, can you talk about that a little bit more?
Yeah, by and large, any drug which is an anti-angiogenesis drug is likely to produce renal dysfunction. So it is very clear that anti-VEGF, which is used systemically, can induce renal dysfunction, can produce proteinuria, can produce thrombotic microangiopathy. So in oncology, actually, we are very much concerned once you use anti-VEGF. So it is very clear that anti-VEGF has a real implication for sure. If you give systemically, we have a lot of patients who had TMA following TMA thrombotic microangiopathy, which produces renal dysfunction, dialysis dependency. And patient is already on treatment for malignancy. So it is actually
but the oncologic dosage, I would argue that's about 100 times higher.
Yeah, I'm coming to that. So, but having said that, once you use anti-VEGF for the local injection, actually the absorption is very less. So, we have seen that this study, which we have looked at 6 months data of the same study, something similar. 30 patients were in the control group, 30 patients were in the treatment group, and we found that there is a significant decline in GFR for those patients who have been given anti-VEGF. So I understand that most of the patients were on ranibizumab, and that is what is probably from our literature says that it has some benefit because the half-life of ranibizumab is less than the others, so the systemic absorption is probably less because of that, and thereby the possibility of renal toxicity is less. But there are a lot of studies which has looked at this. It is actually still a point of debate whether we need to give this or some other drug. But there is a possibility of proteinuria worsening and GFR decline with anti-VEGF drugs for sure. But how do you go about that?
So the next thing that we have to find out is who are the patients at risk of renal worsening when we are giving an anti-VEGF. So that is the thing that we need to, in the next few years, come to find out.
So we can probably risk stratify these patients. A patient who is having a duration of diabetes more than 10 years, patient is having not microalbuminuria but overt proteinuria. Overt proteinuria, microalbuminuria means 30 to 300 milligram in 24 hours. Overt proteinuria means more than 300 milligram, that means more than 500 milligram in proteinuria. So a diabetic patient with overt proteinuria, usually a patient with significant nephropathy with retinopathy, once they come to us, maybe a bit late, will be having a proteinuria more than 1 gram. mostly, and will be having a florid retinopathy. These patients are likely to progress for sure. So such patients need anti-VEGF. Second thing is control of hypertension. The BP is not under control. Obviously, if you give anti-VEGF, it is basically a vasculopath. The hypertension is going to progress, and probably, unless you control the hypertension, is going to.
So you mean to say that anti-VEGF will increase the hypertension?
Yes, the patients who are on anti-VEGF, there is a difficulty in probably.
You're talking about evidence from systemic anti-VEGF or from the ocular anti-VEGF?
Probably from systemic anti-VEGF, but this has to be extrapolated to this also. Because I always tell the patient, this is a very, very pertinent question. Patient, sir, എൻ്റെ creatinine 3 ആണ്. Ophthalmology anti-VEGF എടുക്കാൻ പറഞ്ഞു. പക്ഷേ anti-VEGF എടുത്താൽ kidney function വഷളാവുമെന്ന് പറഞ്ഞു. എനിക്ക് എടുക്കാമോ ഇല്ലയോ? It is not a one-word answer. I always tell them, eye is important or kidney is important. Which is more important? I will say that eye is more important, because if the patient kidney function worsens, we have dialysis, we have transplant, there is a way out. Whereas if the eye is lost, everything is lost. So I try to start my discussion like that, so that I am trying to allay their fears. But I can't categorically say that there is no issue with anti-VEGF. So what we say is that you take the first dose if there is significant indication, and then follow up the GFR. If the GFR is showing, if you're doing monthly anti-VEGF, we can always follow up the GFR. If the GFR is showing a dipping trend, if the proteinuria is doubling, hypertension is getting difficult to control, then patient is having cardiovascular risk factors also, patient having significant peripheral vascular disease, he has history of stroke, then probably I'll be very, very skeptical to continue further injections. This is how we look at it.
So a patient with anti-VEGF, on anti-VEGF, probably requires to be evaluated for his renal disease as we progress, move on, maybe monthly or at least 2 monthly. And if things are not going the way we want, immediately I think we may have to switch from an anti-VEGF to a steroid or something like that. Or maybe in such high-risk patients, we can, maybe start treatment with dexamethasone long-acting implants. Any questions to Dr. Rajesh from the audience? Yeah.
Hello, sir. So if we diagnose a new diabetic retinopathy in our clinic, we usually send them for some baseline investigations. So often they come back with a subset of population will come back with low HB and borderline renal parameters, deranged renal parameter. So I usually send them for a nephrologist opinion. So most of the time they will come back and I ask them what the nephrologists have said. So they usually tell nothing, no specific treatment started. They will check again after 3 months or something. So as an ophthalmologist, we just know that anemia will worsen diabetic retinopathy. So what is the take on this? Like nephropathy treatment itself will correct the anemia, or the nephropathy itself is the cause for anemia? As an ophthalmologist, what should we know?
Yeah, that's a good question. Thanks for that question. So that means I need to elaborate a bit on anemia also. See, anemia in diabetic kidney disease is multifactorial. Even a patient is having a non-diabetic renal disease can have anemia because of the reduction in the erythropoietin. Erythropoietin comes from the kidney. So by and large, theoretically we can say that when the GFR is less than 30, there will be a significant hemoglobin drop which may need erythropoietin supplementation. But practically, this may not be completely correct. So I'm not very sure what is the GFR of the patient whom you refer to the nephrologist. So based on the GFR, if the GFR is proportionately telling you that the fallen GFR has something to do with the anemia, then probably you'll have to start the patient on erythropoietin. If the patient is not needing erythropoietin, then probably you need to look other factors which usually coexist in patient with CKD, like nutritional anemia, iron deficiency, multivitamin deficiency, patient is having some GI loss of blood. So all this has to be looked into, and anemia has to be corrected. There is no question that anemia need to be corrected irrespective of the stage of CKD, which has a significant positive impact so far as diabetic retinopathy is concerned. I understand that probably, I don't know, probably the patient whom you are referred to the nephrologist might be having a normal GFR and maybe having a very minimal proteinuria, which may not have much to be done from the nephrology standpoint, except the fact that patient may need to be started on an ARB to reduce the proteinuria. ARB also can produce ARB is also one of the causes for anemia. That's also important. So patients on ARB with long-standing diabetes, GFR is not that low, tend to be towards the anemic side, which definitely needs correction. It may be with iron supplementation, maybe with other factors, or if the patient having significantly low GFR, which explains the anemia, patient has to be started on erythropoietin. Hope that I have answered your question.
How long it will take, how long it will take the HB to come to a normal level if the nephrologist start on a proper treatment?
A proper treatment depends on what you are giving. If you are starting on erythropoietin, if the GFR is not too low, the hemoglobin will pick up in 6 to 8 weeks time. And the target is around 10 to 11. We will not target around 12 or 30 because if you target more than that, I think Gopi is here to answer that question. The possibility of stroke is more in diabetic CKDs. So the target will be somewhere between 10 to 11, the hemoglobin target. And of course, the iron status also has to be replete. So if you refer a patient to me like this, probably I will check his iron status, I will check his GFR and find out are there any other factors which can contribute to anemia and correct those accordingly.
Thank you, sir.
Thank you very much, Dr. Rajesh.
I think sir has one.
Rajesh, sir. I think GFR is basically calculated from the creatinine, and microalbuminuria is basically the urine routine test. Actually, both these are important. Definitely, both these are important. Often, what we see is that physicians will not be seeing the urine test. They will not see they just skip the urine routine and check the creatinine and reassure the patient. From the nephrology standpoint, the first test a nephrologist is asking for is urine routine. And one more, since you asked that question, one more important thing I would like to highlight is that if the urine dipstick is showing persistent proteinuria of 1 plus or more, there is no need to look for urine microalbuminuria because it has already crossed the microalbuminuric range. The urine dipstick is consistently showing, usually we repeat in 6 weeks time because sometimes stress can produce proteinuria. 2 urine routine tests 6 weeks or 8 weeks apart is showing at least 1 plus albuminuria or above. That means the patient is having patient has gone into macroalbuminuria already. So there is no need to repeat and see whether the patient is microalbuminuria. But if the patient is having long-standing diabetes, there is a possibility of retinopathy. Creatinine is normal, but the urine dipstick is not, urine routine is not showing albuminuria. Urine dipstick is negative for protein. You have to look for microalbuminuria. That means there may be some evidence of microalbuminuria, but that has not progressed into an overt proteinuric range. Okay, thank you, Rajesh. We are running short of time. Let us move to neuro, Dr. Gopi. So let us see what would be the neuro. First of all, can you tell us what happens to a patient with diabetic neuropathy and how it affects the foot more? And many patients may develop diabetic foot infections in the presence of neuropathy. Can you just, in 1 minute, just talk about that? How does neuropathy occur? And what stage of diabetes does neuropathy occur? Is it before retinopathy, after retinopathy? Is it first 10 years or 10 to 30 years? Or later?
Firstly, thank you for inviting me for this conference. Speaking about diabetic neuropathy, it's quite, the pathophysiology of diabetic neuropathy is quite similar to the pathophysiology of diabetic retinopathy. So basically the same things we talk about, the advanced glycosylation end products, the reactive oxygen species and polyol pathway. These are the same things which cause both the retinopathy as well as the neuropathy. So from a clinical point of view, neuropathy, usually patients, their symptoms are more of numbness, they have a tingling sort of sensations. It's almost always in the feet. So neuropathy in diabetes is a length-dependent neuropathy. It means that the symptoms will start essentially in the feet and they will be symmetric. They'll start in both the feet at the same time. So they'll have a bit of burning sensation, bit of numbness in the feet. And gradually as time progresses, this numbness and this burning sensation will progress more proximally. From the feet, it will start up to the ankle and even more proximally. Usually there won't be much of a weakness because of diabetic neuropathy. And in later stages, if the neuropathy progresses to a significant extent, they can have ataxia. Because of the proprioception impairment, because of the nerve damage, the you're unable to maintain your balance. So this is the usual sequence of progression of somebody with diabetic neuropathy.
And the specific treatment, is there any specific treatment?
Right, no. So, firstly, is diabetic neuropathy reversible? The answer is no. So, once the neuropathy starts and the nerve damage actually sets in and there is actual axonal loss, there isn't much we can do to revert the axonal loss. So, what we can do is, similar to retinopathy, we can try for aggressive glycemic control so as to prevent the further progression of the neuropathy. And apart from glycemic control, a bit of role for general exercise, like Nisha madam was speaking about 150 minutes of physical activity per week and weight training. It works for diabetic neuropathy also to some extent in preventing the progression. But whether diabetic neuropathy is reversible, no. But symptomatically, we do offer options. Whenever a patient has very disabling paresthesias, painful burning sensations, we give neuropathic pain medications like gabapentin or pregabalin, which are all symptomatic. They have nothing to do with the disease course of diabetic neuropathy. They just help with the patient's symptoms.
Okay. Now, that's a chronic problem that, and many patients who do not have sensations in the feet develop ulcers, and then they become infected, and that is a cause of a lot of problems, hospitalization, and many may move into sepsis also. Now let us shift gears and move into retinal vein occlusion, arterial occlusion sort of a pathology. So we have a patient who had a retinal vein occlusion. So which means that there is some thrombosis effect which has happened somewhere in the body. Would you be concerned that this patient may develop a CVA later, or do we start ecosprin or clopilate in the patients with CRVOs?
That's a very good question. So, similar to diabetic retinopathy, the pathophysiology of retinal vein occlusions, not the pathophysiology, the risk factors which are associated with retinal vein occlusions and for the development of stroke are quite similar. You generally see both these conditions in advanced age, patients with diabetes, hypertension, beta vascular risk factors, obesity, kidney disease. These are the sort of patients who generally develop both retinal venous occlusion as well as strokes. So given that, whenever you have somebody who comes with retinal venous occlusion, their overall pretest possibility of developing a stroke are quite high compared to the general population. Now, whether there is a role for aspirin as a primary prevention. So this is a very contested sort of question. So what guidelines say is that if the risk is significantly outweighing the bleeding risk with aspirin, you are justified in starting antiplatelet in this situation. Again, the risk we generally stratify based on risk scores, like the Framingham risk score, your 10-year cardiovascular disease risk scores, that's what we calculate. So generally in patients who have retinal venous occlusions in the setting of so many other vascular risk factors, including a family history of possible atherosclerotic cardiovascular disease, their risk scores are likely to be quite high, and in that set of population, you are justified in starting antiplatelet like aspirin, provided they don't have a significant risk for bleeding. For example, they are already on, say, anticoagulant like warfarin for another cause. They have a past history of GI bleed, peptic ulcer bleed, hemorrhoids. So these sort of patients, maybe the risks may be outweighing the benefits. But otherwise, for an overall low bleeding risk patient, you are justified in starting aspirin in such a patient.
And if there is a history of central retinal artery occlusion, now we are talking about vein occlusion in which the evidence is thin. Yes. But what about an artery occlusion, which is 90% of times occurring because of an embolism?
Okay. So central retinal artery occlusion is essentially a stroke. It's a stroke which is happening to your retina. So in effect, the pathophysiology, the reason why you have central retinal artery occlusion is quite similar to the reason why you have strokes. Mostly it is related to carotid disease. You have carotid plaques which are embolizing into the retinal artery and causing occlusion. That is the usual cause. And again, as was discussed in the previous talk, atrial fibrillation is a common cause. So always have to look for atrial fibrillation. So generally, central arterial occlusion, we generally see it as a stroke which has happened in the eye rather than a different entity altogether. So all the evaluations we do for a patient who presents with the stroke and all the management we do for a patient who comes with stroke applies for central arterial occlusion also. And again, so in stroke and for central retinal artery occlusion also, what you start, whether you start on an antiplatelet, whether you start on anticoagulant, that depends upon what is the etiology of the event. Right? If you're seeing a carotid atherosclerosis at the etiology, then you start the patient on dual antiplatelet. If you're finding atrial fibrillation as the cause for the CRAO, then you start on anticoagulation rather than antiplatelets. So yes, so like Sir said, CRAO is essentially it's just an extension of a stroke. It's just a stroke which is happening in a usually, which is happening in a retinal vessel. Again, there are instances like genital arteritis where the genital artery is much more likely to involve the retinal vessels as compared to the other central vessels. So usually we don't see so much of strokes in GCA as much as we see AION or CRAOs. So that is a different set of population, but usually atherosclerosis and AF are the usual causes that we see in CRAO as well as for stroke.
Okay, so the next question is an acute CRAO is coming, like within 2 hours. So what would be your take? Would you take the patient immediately to the cath lab, or would you want to stabilize the patient and give the patient tissue plasminogen activator, or what would be your thought process? We as ophthalmologists would be just doing the ocular massage, probably paracentesis, reducing the pressure to somehow remove the embolus from the central artery. But what would be your approach to such a patient?
Right. So, there is evidence for intravenous thrombolysis in patients for
Within how?
So 4.5 hours for all strokes. Like I said, strokes, CRAOs, anything related to stroke, our cutoff is 4.5 hours.
No, but the ischemic time in the brain is about 4 minutes. Ischemic time in the retina is considered to be about 90 minutes. Is there some leeway for retina in that?
Not just that. So it's when we are actually revascularizing, we are trying to save what is called the penumbra. There is a part of the retina or there is a part of the brain in a case of stroke which is ischemic but not infarcted. So that is the part we are trying to salvage by revascularization. So that is where this 4.5 hours sort of time frame comes in. Till 4.5 hours, overall your benefits that you expect from revascularizing the penumbra outweighs your bleeding risk. Beyond 4.5 hours, your risks are much higher compared to the benefits. So that is why we have this 4.5 hour cutoff. So it is reasonable to thrombolyze patients with CRAO. But again, do people actually do that? Do we have much experience doing that? I'm not really sure. I have never done thrombolysis for a patient with CRAO.
Whereas intravenous thrombolysis?
Intravenous thrombolysis. So mechanical thrombectomy is generally not. So these vessels are not usually reachable by mechanical thrombectomy. They are very distal vessels. Okay. So unlikely that we'll be able to reach a catheter all the way up to that and remove the embolus. So yeah, for practical purposes, revascularization with intravenous thrombolysis is what can be offered.
Thank you, Gopi. Is there any question to the neurologists here? If not, we will move to the section on cardiology. Dr. Sarita. So first of all, Sarita is championing the Women's Heart program. So how is a woman's heart different? Ophthalmologists, 90% of ophthalmologists are women. What do you have to tell them? Apart from the heart being large and emotional, what is the difference?
Okay. Thank you, Dr. Mini, for having me in KAAZCHA 2025 on a Sunday. And thank you, Gopal sir, for having me in this team. Despite I am the only lady interventional cardiologist in a team of 10 in Amrita Institute of Medical Sciences. So that speaks about women heart. So I declare myself as a public health expert in this panel, and I am not the cardiologist. So we are going to have a discussion from now on based on all the points which were discussed. I actually requested Gopal sir, please keep me last, though Gopi is the only one who is younger to me. And this is my better half. So Nisha madam, I call Chechi because she's a gold medalist throughout, and my only ambition in medical school was to study like her. So we all are from the same alumni, we still work together. So coming back to women heart. Why women heart? It's an excellent question, sir, because I'll touch upon all the points as a public health expert. It's just a message. These are not points, because I would want to know from the busy ophthalmologist that why I was interested. I want you all to know why I became interested in women heart. It is not because I have nothing against men. This is my better half, that's why I said. His heart is most important for me in the world than anybody else's. So we have to understand that there is a lot of gap between a super specialist, a specialist, and a public health expert. We are unfortunate not to have public health experts as doctors, specialized public health experts in Kerala. We are very unfortunate, because my quest as to why am I seeing so much of acute heart attacks in the society, despite Kerala being the state with the highest literacy rate. Where are we going wrong? We are doing so much of high volume interventions in a state where the people are aware that heart attack is a cause of death. So we need to remember that heart is an organ which works continuously. All what we have discussed till now, we should remember that the heart beats for us even while we are sleeping. So what are we worried about? We are worried about that massive heart attack which can kill us during sleep. And how does heart attack occur? It is by plaque rupture. And how does a plaque rupture? The plaque is like the yellow of a bullseye. The yellow of a bullseye. It needn't be a tight block. So there comes a question. You all are sending, not you all, we all undergo cardiovascular risk stratification by doing a treadmill. Please understand that a treadmill testing, though it is a stress testing to the heart, it does not have a warranty or a guarantee period. It just tells us that at that particular moment, while running on treadmill, that person's effort tolerance is good enough that he or she has attained the metabolic equivalent which the cardiologist is looking for to say that as I'm speaking to you, your heart is okay. You can have a heart attack on that night. Please understand that. So the treadmill does not tell us that your patient will never have a heart attack. So that is where it comes into the picture. On a busy ophthalmology clinic, how can you help your patients? I heard so many doctors who are really interested in helping their patients. I don't have time. In my 50 patients in Amrita, where we have to do an EMR recording, I can't imagine talking to the patient regarding what you should eat, what you should do, what your wife should cook, and what your children should do. Please understand few points. The first changes in the interior lining of the endothelium called the fatty streak, it happens in the first decade of life, which means in the first 10 years of life. So are we doing justice to our children by swiggying them KFC, McDonald's? I'm talking this inside the four walls because I have nothing against those people. We are 30 or 3 or 4 decades behind the developed nation, I would say. We are still developing, but we are not understanding that our kids' heart attacks are going to be treated by their own classmates who are going to study well and become toppers and become interventional cardiologists. Please understand that. So we were just having a chat, all of us are Amritites, we just had a coffee and a chat as to what sir is going to ask each one of us. I met Gopal sir as a student way back in 2006 when I joined Amrita after my MD medicine to pursue DNB cardiology. And my then head of the department gave me a thesis topic. You know what it was? He said, you can go and meet this faculty and find out that a fundus fluorescence, we do a coronary angiogram in the cath lab. As you all know, Amrita's interventional cardiology started way back in 1998 as a 3rd private cath lab in the state of Kerala. So there was a period when the cath lab was not switched off. Such a high volume center, we are doing coronary angiography through a radial artery or through a femoral artery using the iodinated contrast which our nephrologist was alluding to and the amount of contrast, etc., etc. So please understand that should I stop?
No, Sarita, I would just like you to switch on, diabetic patients.
Yeah, So that's why I said I am not a cardiologist here. Please understand I'm not a cardiologist. I would want to hear from you all. I would say that you are all busy ophthalmologists. Please understand that as far as a cardiologist is concerned, the risk factor modification is most important. We are what we eat. So sir is concerned about diabetes. I am concerned about way more things. Diabetes, I will just quickly say, modifiable risk factor, non-modifiable risk factor. There are only 2 non-modifiable risk factors, that is age and gender. We cannot change that. All the others for a cardiologist are important. So there comes about diabetes. Diabetes is very important risk factor. I would like to say that 3 group of patients we can have silent heart attack, silent myocardial infarction. So those are diabetes, what sir is concerned about. Women can have silent heart attack. That is why Women Heart Center, and elderly. can have silent heart attack. I think
Now
yeah.
let's just move gears. I mean, that's very important perspective that that has probably jittered us in terms of our heart's health rather than our patient's heart's health. Now let me just bring in another perspective here. Like we, just like nephrologists, we do give anti-VEGF. So what do you have to say about anti-VEGF in the presence of cardiological problems? Because a lot of these patients with diabetes who develop diabetic retinopathy had been coronary artery disease patients. They had been on treatment for quite some time. So we actively do not inject in patients who are having active coronary problem for last 3 months. But what about older patients? Do you risk stratify in any way?
Actually, no, sir. I would put it this way. You, as ophthalmologist, can help me as cardiologist in telling whether my patient has an established coronary artery disease or he just needs to be screened, which means every heart attack, the pathophysiology we have learned is atherosclerosis. So what we see in the retinal artery is arteriosclerosis. And what we were talking about stroke and Dr. Gopi and me are concerned are atherosclerosis of the major vessels. It is all the same. So anybody having central retinal arteriosclerosis, it is an alarming sign that I should be careful. My patient already has an established cardiovascular disease. I have to very closely follow up that patient's risk factor so that the patient does not develop a myocardial infarction under my follow-up.
Okay, thank you very much. One more question. See, as we do surgeries, cataract surgery generally now we do not stop ecosprin or clopilate in patients with coronary artery disease. Whereas in retinal surgery we definitely need to stop. Or in a patient who has proliferative diabetic disease or age-related macular degeneration, which is actively neovascularizations are there, we would ask them to stop antiplatelets for few days or few weeks. How do you consider the risk of, if you stop it, how do you stratify the risk of having a heart attack?
So as a cardiologist, I'm concerned whether my patient has already undergone an angioplasty or the patient is on antiplatelet for a primary prophylaxis. If the patient is on antiplatelet for primary prophylaxis, I comfortably say the patient, please stop as advised by the ophthalmologist and please restart when the ophthalmologist is comfortable to do so. But if I have done an angioplasty for that patient, it is a must that the patient should meet me and I need to see when I did the angioplasty. If the angioplasty was done with a bare metal stent, which we hardly do these days, it can be stopped after 1 month because the endothelial lining is developed by 1 month. So 1 month post bare metal stenting, the strategy is the same as I have already explained in an established cardiovascular disease. But in a new drug-eluting stent angioplasty, please remember that if the patient's vision is not going to be that much threatened and you can wait for 1 year, I would be happy that my patient also waits for 1 year because stopping dual antiplatelets within 1 year, there is a risk of acute stent thrombosis which can cause acute myocardial infarction.
So after 1 year, the risk is less?
The risk is the same as a patient who has not undergone angioplasty.
Okay, so any questions to Dr. Sarita also? Yeah, Andrew sir.
It is not directly to Sarita, neurologist. Dr. Prakash told about the CRA occlusion, the time and everything. Any role of, nowadays, a lot of thrombectomy, thrombolysis are going on. Any role in central retinal artery occlusion, this thrombectomy or thrombolysis?
I answered that question, but you can.
Yes, sir. So there is evidence for IV thrombolysis in patients with CRA also. There are many cases also which has looked into this. So the time window is generally 4.5 hours. Within 4.5 hours, it is reasonable to thrombolyze a patient with the central artery occlusion. But there isn't a lot of evidence in that. There's not much of an experience in centers doing this. Mostly because by the time most patients are diagnosed with the CRAO, they pass the 4.5 hours boundary. But it is a reasonably safe option. Mechanical IV thrombolysis usually especially if it's a very organ-limited sort of thrombus, doesn't lead to much of complications like hemorrhage. It's reasonably safe and should be considered in these patients.
Maybe to prevent a recurrent stroke later. No?
Not recurrence actually. So it's for the current. It's salvaging the penumbra, like I said previously. Whatever is ischemic, we can salvage by doing it.
Okay.
Only
Now I think
thrombolysis,
we should not.
no thrombectomy.
So thrombectomy, so if it's a large vessel, if the thrombus is quite proximal, if it's in the ICA, that is the only situation where you can actually reach a catheter and take out the thrombus. If the thrombus is inside the central retinal artery, it is unlikely, we won't be able to reach the thrombus. So practically it is not possible.
So I think it is not prudent to stand between you and lunch now. I thank you. I think all of you should give a great hand, big hand to these panelists who have done really well, enlightened us. Thank you very much, Dr. Nish.